friends, once again a warm welcome to another episode of my YouTube channel Future Midwife. Today I will discuss about intrauterine growth retardation. Intrauterine growth retardation is also called intrauterine growth restriction. IUGR refers to a condition in which a fetus is smaller than the expected for its gestational age, typically below the 10th percentile. This condition affects a substantial proportion of pregnancies globally, impacting 5 to 10% of all pregnancies and 1 in 10 newborns. IUGR dramatically increased the risk of adverse outcome, raising perinatal mortality rate by 4 to 8 times compared to normally grown fetus. It is also associated with 30 to 40% of all stillbirth and contributed to significant neonatal mortality, underscoring the critical need for early detection and comprehensive management. Next, I will discuss about the causes and risk factors of intrauterine growth restriction. In that, first one is maternal factors, which include hypertension or preeclampsia, malnutrition or anemia, smoking, alcohol intake or drug abuse, and last one is infections such as TORCH. The second one is placental factors, which include placental insufficiency, abnormal cord insertion, placental abruption or infarct. The third one is fetal factors, which include chromosomal abnormalities such as trisomy 13 and 18, congenital anomalies, and multiple gestation. So these are the causes and risk factors of intrauterine growth restriction. Now I will explain about the types of IUGR. The types of IUGR are mainly categorized into two ways, that is symmetrical IUGR and asymmetrical IUGR. So first we will see the symmetrical IUGR. In case of symmetrical IUGR, the fetus will have proportionately small head, abdomen and limbs. This condition will occur before 28 weeks. The main causes are chromosomal abnormalities and severe infection. This condition is account for 20 to 30% of IUGR cases. When it comes to the asymmetrical IUGR, the fetus will have a normal head size, disproportionately small abdomen. The onset will be after 28 weeks of gestation. The main causes are placental insufficiency in case of maternal hypertension, which is account for 70 to 80% of IUGR cases. Next is the monitoring and assessment strategies of intrauterine growth restriction. In that, first one is fetal surveillance. Regular non-stress test and biophysical profiles are vital. These are typically performed twice weekly. Second one is Doppler velocimetry. Umbilical artery Doppler assess placental function. Abnormal flow indicate severe fetal compromise. The third one is MCA Doppler. Middle cerebral artery Doppler shows brain sparing effect. This indicates fetal hypoxemia. The last one is growth scan. Growth scans are done every 2 to 3 weeks. They track fetal growth velocity and estimated fetal weight. Here we reach the treatment and management of IUGR. The management of IUGR focus on monitoring fetal well-being, optimizing maternal health, and deciding the best time and method of delivery to reduce the risk for the baby. In that, first one is identify and treat underlying causes. Maternal conditions such as hypertension, diabetes, anemia should be identified and managed. Infections such as TORCH and malaria must be screened for and treated appropriately. Substance abuse such as alcohol, tobacco and other drugs must be stopped immediately. The second management is the nutritional support. Improve the maternal nutrition by means of high protein, high calorie diet. Iron, folic acid and other prenatal vitamins also can be included. Apart from that, nutritional supplements should be taken if it is indicated. The third one is fetal surveillance. This is the cornerstone of IUGR management. In that, first one is ultrasound assessment. It should be done every 2 to 4 weeks. It helps to measure the estimated fetal weight, abdominal circumferences, amniotic fluid index, and biophysical profile. The Doppler studies also can be performed in order to identify the blood flow in umbilical artery, middle cerebral artery, and ductus venosus. Abnormal flow suggests placental insufficiency and fetal hypoxia. The last screening is non-stress test. It helps to monitor the fetal heart rate pattern. Abnormal result may indicate fetal distress. If the condition is severe or worsening, hospital admission is necessary, which helps for the close monitoring of mother and fetus. If the gestational weeks is less than 34 weeks, we can administer corticosteroids such as beta-methazone. It helps for the fetal lung maturity. If the gestational age is less than 32 weeks, we can also administer magnesium sulfate for the neuroprotection. Here I will explain about the timing and mode of delivery in case of intrauterine growth restriction. The timing and mode of delivery are critical. For isolated term IUGR with normal Dopplers, delivery is typically planned between 38 to 39 weeks. Preterm IUGR with abnormal ultrasound Doppler often necessitate delivery at 34 to 37 weeks, while absent or reversed ultrasound flow may require delivery as early as 30 to 34 weeks. In case of severe fetal compromise, example abnormal ductus venosus, delivery may occur as early as 28 to 30 weeks. We can go for cesarean section in case of labor intolerance. Postnatal care focus on close monitoring for neonatal complications like hypoglycemia and hypothermia, along with long-term neurodevelopmental follow-up to optimize outcome for these vulnerable infants. The complications and prevention will be displayed on the slide. Please have a look on it. So here we can wind up our today's topic. I hope all of you understood about the intrauterine growth retardation. So in the next class, we will meet with another episode of midwifery topic. Till that, take care. Bye-bye.